Good evening, everyone. Welcome to iFocus Lecture 123. Today is the third session for Glaucoma Medical Management, and we have our own Dr. Prateep Vyas. He'll be speaking on Carbonic Anhydrase inhibitors, cholinergic agents, hyperosmotics, ROCK inhibitors, and other new drugs. I request Dr. Vanita ma'am to introduce Dr. Prateep sir.
Thank you very much, Christy. Actually, it's always a pleasure to reintroduce Dr. Prateep Vyas here again to the audience who have joined in today. Dr. Prateep Vyas is very much part of Center for Sight at the moment. He is medical director at Indore. He brings with him not only 30 plus years of experience in ophthalmology, in particular glaucoma and anterior segment phacoemulsification and oculoplasty as well. He has held several leadership positions before he joined as medical director at Center for Sight in Indore. He has been ex-medical director and trustee at the Sri Ganapati Nethralaya in Jalna, ex-medical director at the Joytram Nethralaya in Indore. He has also been past president of the Indore Divisional Ophthalmological Society, as well as ex-honorary general secretary of the Glaucoma Society of India. He also is the member of the editorial board of the Indian Journal of Ophthalmology. So where rewards and recognitions are concerned, he has several. I'll name a few. He passed out as the best PG student and received the Rai Bahadur S.H. Pandit Award. He has received the Marathwada Bhushan Award, the Sadguru Award, Bombay Ophthalmic Association Gold Medal, and has delivered the Vagle Oration. In fact, he has been at invited talks and presentations in several national and international conferences. And today he is going to deliver a lecture for us on, as Christy said, carbonic anhydrase inhibitors, cholinergic agents, hyperosmotics, ROCK inhibitors, and the newer drugs. This today is the last of a series of medical management. Over to you, Dr. Prateep.
Thank you, Dr. Vanita, for your kind introduction. Thanks, Dr. Santosh, Dr. Harsh, for this opportunity. I will share my screen. Am I audible and the slides are visible?
Yeah, very clear.
Good. So good evening, friends. I don't know whether any hot seaters are there. Is there any hot seaters, Vanita?
3 already joined.
Okay.
Dr. Jiva, Dr. Soni, Dr. Veer.
Okay, so if there are few, then I may ask some questions. So I will be talking to you on the cholinergics, hyperosmotics, carbonic anhydrase inhibitor, and the ROCK inhibitors. And the lecture number is lucky charm 123. That's wonderful. I do not have any financial disclosure, but I want to disclose that I have copied a few schematic diagram for a non-peer review journal just for teaching purposes. So just to let down the foundation of this lecture, all of you know that what is glaucoma. Glaucoma is an optic neuropathy along with the correlating visual field changes. What causes this? This is because of the death of the ganglion cells. And why the death of the ganglion cell occurs? That is because of the several factors. And one is the mechanical, that is the intraocular pressure. Apart from the mechanical factors, there are metabolic, neurogenic, and the vascular factors responsible for the death of the ganglion cells. First, the patient loses the field of the vision, and then gradually he loses the vision as well. There are many landmark, multi-center, prospective, randomized control trials have indicated that the lowering of the intraocular pressure is overall beneficial for the treatment of the glaucoma patients. So how we can lower the intraocular pressure? There are various means. The mainstay of the treatment in most of the glaucoma is the medical therapy. Apart from that, we do the laser treatment for some of the patient, that is SLT and ALT. And the last resort is the surgery for a selected few patients. And the objective of all these treatment modalities is to lower the intraocular pressure. So I would be talking on the medical management, and I would be covering the 4 different class of medications. So the history of the medical therapy goes way back to about 150 years before. Pilocarpine was introduced in 1875, and still it is one of the important drug in treating the glaucoma. We will go down up to the ROCK inhibitor, and we will see whether they really ROCK or they do not. So it's so many drugs I would be covering. Basically, there are 7 classes of the ocular hypotensive agents, not basically the topical. That's a wrong thing which I have written. The prostaglandin analogues and the beta adrenergic blocker and the alpha-2 adrenergic agonist has already been covered in the previous talk. So the remaining 4 classes are the cholinergic agonist, that is the pilocarpine. Obviously, the Carbonic is not available in our country. The hyperosmotic agent, we very often uses the mannitol and the glycerol, the ascorbic acid and the urea, and there are so many others as well, which either seldomly used or they are not used. I have never used. Carbonic anhydrase inhibitor, it's a class of a medication in the glaucoma medication, which is delivered not only topically, but obviously by different routes as well. The oral pills are available, and intravenous acetazolamide is also available. So that is the only class of medication for treatment of glaucoma, which can be delivered orally, topically, as well as intravenous. And the ROCK inhibitors, they are the new group of medication, a new class altogether. So obviously we would be seeing whether they really ROCK or they do not ROCK. And these are the 2 repasudil and the nitazoxanide molecules, which are already made available, biosimilar in our country as well. So I would start my talk with the cholinergic agonist, and that is the pilocarpine. It's an age-old drug, but still, believe me, it's not applicated yet. You are seeing 2 Rolls Royce over here, the Phantom and the old one, which I clipped from the Jodhpur Museum. And believe me, if you want to buy, this one will be more expensive. Similarly, the pilocarpine has its own role to play, and it's very important, and no other class of medication can substitute the role of pilocarpine. The pilocarpine is a cholinergic drug, a parasympathomimetic and muscarinic agonist agent. Obviously, I cannot help with all this terminology because the time may not permit. The mechanism of action is primarily a mechanical. It causes the miosis, and it prevents the crowding of the iris from the angle structure. Apart from this, a very important, which you must try to understand, is that it tries to pull the scleral spur posteriorly and internally. Okay, and because of that, it produces some changes in the ciliary body and the trabecular meshwork. Just try to understand from this schematic diagram. The first is that it pulls the iris inward because of its action over the sphincter, and thus there is no crowding at the angle. So the iris is out from this and the angle recess is open, and this mechanism is very helpful in angle fissure glaucoma, because once the iris is out, the aqueous can egress comfortably from trabecular meshwork to the canal of Schlemm, to the collector channel, and so on and so forth. But look at the other mechanism, what it is. It pulls down the scleral spur internally and posteriorly. Okay. number one. And number two, the pilocarpine is not truly, totally cholinergic agonist. It's a partially cholinergic agonist. I will tell you the importance of both the things. Once it pulls the scleral spur posteriorly and internally, there is a relaxation of the trabecular meshwork and the widening of the canal of Schlemm. So because of this mechanism, it is quite helpful in primary open-angle glaucoma as well, because it enhances the outflow of the aqueous through the conventional pathway. And as I said just now, that it is not fully cholinergic agonist, it's a partially cholinergic agonist. So because of the partially cholinergic agonist, it does not constrict the ciliary muscle fiber very densely and compactly. And that's why the spaces are available over here. And there is no barrier between the ciliary muscle and the trabecular meshwork. There is no endothelial cells or no other barrier or endothelial membrane. So because of that, there are spaces available between the ciliary muscle. So through the non-conventional pathway also, there is a flow of the aqueous. So that is the two mechanism which helps the usage of pilocarpine in open-angle glaucoma as well. And that is the reply of the question also, where the many glaucomatologists also ask whether it is additive to our prostaglandin analog. So that is why it is additive to the PG analog as well, because once there are spaces available and the PG analog acts through this mechanism, through UV scleral outflow, and that's why it helps, and it can be given along with PG analog as well. It reduces the intraocular pressure by approximately 10 to 20% from the baseline. It's available in various concentration, varying from 0.5% to 6%. But unfortunately, because it's a regulated drug, it's not manufactured by many companies. And to the best of my knowledge, it's only available in one concentration, that's 2%. 0.5% is available only for intracameral use, and cataract surgeon, they are using intracamerally for their cataract surgeries. Pilocarpine 4% concentration is available in as a gel, but unfortunately, again, it's not available in our country. And obviously, 1 to 2% is most widely used by the glaucoma patients, for the glaucoma patient by the glaucomatologist. The chronic use of this drug is limited because number one is the efficacy, as you can see that it's inferior to the beta blocker. The compliance factor, because it causes some side effect, and because of that, the compliance is poor. Its indications are the most important is the angle-closure disease. It's also used in the plateau iris. It's used in the pigmentary glaucoma, pseudoexfoliation glaucoma, primary open-angle glaucoma, particularly the patient who are pseudophakic or aphakic, and a phakic patient with a clear lens. The miscellaneous uses are the AD's pupil, and during the intraocular surgeries, the cataract surgeons uses this. So for the acute angle-closure glaucoma management, it's uses very often, very frequently, and the 2% solution is instilled at frequent interval to constrict the pupil. And that is one of my patients who had acute attack of the angle-closure disease. And obviously, after the breaking of the attack, the PI was performed, and this patient was given the pilocarpine frequently, and you can see that the pupil has become round, circular, and his attack was broken with the uses of the pilocarpine. And this is the plateau iris, and you can see that in this and the same mechanism work for the angle-closure glaucoma also. It prevents the crowding of the iris at the angle. It pulls the iris away from the angle structure, and that's why it facilitates the aggression of the aqueous to the conventional pathway. How it is useful in the pseudoexfoliation? You can see that it causes the miosis, and because of this, there is hardly any movement of the pupil. And if there is no movement of the pupil, then it avoids the fraction of the posterior surface of the iris to the lens surface and to the cernes, and so there is a less release of the exfoliative material, and that's why it can be useful in the pseudoexfoliation glaucoma as well. The same mechanism works for the pigmented dispersion syndrome because of the rubbing of the posterior surface of the iris, lots of pigment gets released. And if you to keep the pupil biased, then this pigment does not releases, and that is why it may help you. But why is the people says that it is abdicated, or it should not be used, or they are not using so much, or the companies are not manufacturing, at least in India, because of so many disadvantages pilocarpine has. Number one, it causes the meiosis, and because of that, it causes the visual disturbances. In the young patient in particular, it causes the broache, and it causes the blurred vision secondary to the fluctuating myopia, because the iris lens diaphragm moves forward, so there is a myopic shift and the patient's vision becomes little blurred. Obviously, in the inflammatory condition, it cannot be used because the aqueous barrier gets disturbed, and it causes lots of flare in the aqueous humor. Myopic patient, it should be avoided because there is a risk of retinal detachment. And the patient with the cataract, the constricted pupil is a limited factor. And if you are using for a long term, then the pupil remain myosed and the cataract surgery becomes difficult, and you have to use the other acts to dilate the pupil or to expand the pupil. The small pupil can complicate the cataract extraction. So you cannot use the pilocarpine if the patient has this kind of a cataract, because once they will start using, their vision will immediately become blurred, and the next day patient will rush to you and will say that I can't see anything. And in high myope also we should not use, because once there is a contraction of the ciliary muscles, there is a pull to the peripheral retina, and if there is an existing tear or the break, then there is a risk of the retinal detachment. And many of the patients will end up with retinal detachment. So in summary about the pilocarpine is one of the oldest anti-glaucoma drugs. In spite of the certain limitation, it has its own place in glaucoma management, in particular angle-closure disease. And it is the least expensive anti-glaucoma drug available in the market. Now the next will be the hyperosmotic agent. The hyperosmotic agent are used basically to reduce the intra-acute elevation of IOP for short term. And indication are the acute angle-closure glaucoma, lens-induced glaucoma, the aqueous misdirection, some secondary glaucoma where there is acute elevation of IOP, in particular the uveitic glaucoma and chromatic glaucoma, and sometimes it's used as a preoperative for the reduction of elevation of the IOP. When you are doing the cataract surgery and there is a sudden vitreous aphthous, then to push back the vitreous, you may use the hyperosmotic agent on the table. Mechanism of action: the hyperosmotic agents lower the intraocular pressure by creating an osmotic gradient between the blood and the ocular fluid, rapidly increasing the blood osmolarity by around 20 to 30 milliosmol per liter, result in the loss of water from the eye to the hyperosmotic plasma. This transfer of water from the eye to the circulation is manifested by a decrease in the intraocular pressure. Let us see this mechanism over here. Once there is a hyperosmolarity in the blood because of the hyperosmotic agent, then there is the outflow of the fluid from inside the eye, and the aqueous anterior chamber and the posterior chamber gush out of the eye, and similarly the water flows out of the vitreous cavity to the blood, and there is a regression of the vitreous. So once the vitreous body contracts, then the iris lens diaphragm push behind, and the more space is available in the anterior chamber. So it facilitates the aqueous egression, particularly in angle-closure disease, and probably it might be useful in aqueous misdirection syndrome, and more so during surgery when the AC becomes very shallow and the pressure rises. You can give the bolus of the intravenous mannitol. So that is the mechanism of action. The hyperosmotic agent which we use is the mannitol 20%, very frequently used in our practice. The oral Grislon is seldomly used, and the other hyperosmotic agent I have never used in my practice. So mannitol is given intravenously It can be given either 20 ml bolus on table for intraoperative uses, or the dose of the mannitol you will be taught as a 1.2 to 1.6 gram per kg body weight. But don't put your brain for calculating the dose. The simple thing is that you have to give 6 to 8 ml per kg body weight of 20% mannitol. It comes to around 300 to 350 ml in an average body weight person. Oral glycerol is given as a 50% solution. It's available as a 98, 99% solution. So the dose is 0.5 to 1.5 gram per kg body weight. Simple way to remember is that you have to give 30 ml diluted in either fruit juice or in colas or something like thumbs up or so on and so forth, and 3 to 4 times in a day. The important side effect is the nausea, vomiting, diarrhea are the frequently encountered conditions. So these are very useful in, yes, as I said, acute angle fluorescent disease. Apart from that, the less induced glaucoma, both in the phacolytic as well as the phacomorphic. In phacomorphic, it's very useful because it immediately increases the AC volume as well. The all hyperosmotic agents, they have their effect within 15 to 20 minutes, but last only for 3 to 4 hours. And again, after that, there is rise in the intraocular pressure if you have not treated the primary cause of the elevation of IOP. The contraindications are well-established anuria, the severe dehydration, frank or impending acute pulmonary edema, severe cardiac decompensation, and should be used with caution in patients with some cardiac conditions, some renal pathologies, hepatic pathologies, pulmonary conditions, and diabetics. In diabetes, you have to use with caution because there is a risk of ketoacidosis with both the mannitol as well as with the glycerol. Biggest disadvantage is the rebound of the IOP, which is very common. Once you have given the mannitol or the glycerol, the fluid flow from the low osmolarity to high osmolarity, and reverse happens after some time when there is a hypoosmotic condition in the vitreous, and then the fluid flows from the blood to the vitreous, and then again vitreous get hydrated, and there again elevation, acute elevation of the IOP. So this rebound of IOP is very bad. So you have to be very, very careful, and you have to treat the primary cause of elevation of IOP immediately as soon as the pressure goes down. The polyuria, if you are giving to a patient before surgery, then make sure that the patient go to the toilet first and then you take the patient for surgery. Otherwise, the patient will give you trouble on table. Diabetic patient, I have already said that you have to be very, very careful. Sometimes it may cause life-threatening side effect like ketoacidosis. And in spite of all these many times, they are savior to us because they reduces the intraocular pressure immediately and to a significant level, which none of our medication can reduce the intraocular pressure to that extent. So the third class of medication is the carbonic anhydrase inhibitor. As I said earlier, it's the only class of drug available for the management of glaucoma, which can be administered orally, intravenously, as well as in the topical form. The drugs are acetazolamide as the oral pills. Unfortunately, the intravenous ampoules are not available in our country. The second is the methazolamide. Methazolamide is a very good drug. It's not as potent as the acetazolamide, but the side effects are much less and can be given for a longer duration. It comes as a 50 milligram tablet, but unfortunately, it's not available in our country. And the topical medications are the dorzolamide and the brinzolamide. Remember that they all have the sulfonamides group of drug. They fall into that group of drug. So any patients having allergy to sulfa, we should not give this drug, or if at all is necessary, then with very caution and very carefully. Just try to understand the mode of action for this drug. I will tell you in a better way in the next diagram. The important thing is that they are carbonic anhydrase inhibitor. The carbonic anhydrase enzyme is present throughout the body and so is in the ciliary body. In the ciliary body, it's the carbonic anhydrase 2. There are several types of carbonic anhydrase. So this carbonic anhydrase enzyme is basically helpful for the aqueous formation. So once we inhibit the carbonic anhydrase enzyme, then there is a less production of the aqueous, and it decreases the IOP by around 18 to 22% by inhibiting the carbonic anhydrase enzyme. Now let us see that how it works. This is the cell body, and because of the metabolism, carbon dioxide is liberated, and to consume this carbon dioxide and to throw out this carbon dioxide, the carbonic anhydrase enzyme is present. It is a catalyst for throwing out the carbon dioxide from the cells because it is harmful. How that also we would see. So this carbon dioxide is bound with the water and forms the bicarbonate and the hydrogen ion. And the carbonic anhydrase is a catalyst for this equation. So this bicarbonate, when it is formed, it is excreted out or thrown out of the cell body. So once there are more anion, because it carries a negative valency, so once there are more anion, to compensate this negativity, the sodium comes out and carries the positive valency. So because of that, the hyperosmolarity is created in the extracellular space. And to negate this, there is a efflux or the flux of the water from the blood to this space, and that is how the aqueous humor is formed. So if we inhibit this mechanism, then obviously there will be a less bicarbonate and there will be a less bicarbonate over here, and that's why the sodium will not be pumped out. So there will be less osmolarity, and that is how it reduces the intraocular pressure by reducing the aqueous humor formation. That is the mechanism of action. The carbonic anhydrase inhibitor systemic doses, the acetazolamide is given as a 15 milligram per kg body weight. So it translates into approximately 250 milligram tablet, either 3 to 4 times in a day. Sustained release acetazolamide tablets are pretty much available in Indian market as well. If you are using sustained release tablet, then it's given 250 milligram twice a day. Methazolamide, as I said, it's given 50 milligram twice a day. Unfortunately, it's not available in Indian market. The topical carbonic anhydrase inhibitor are the dorzolamide and brinzolamide. Dorzolamide is available as a 2% solution, but brinzolamide is 1% solution. The important difference is that the dorzolamide has an acidic pH, so it is less tolerable, and the brinzolamide has a neutral pH. Dorzolamide is given as a thrice a day, and the brinzolamide is twice a day. Dorzolamide is a clear solution, and the brinzolamide is available in a suspension form. Brinzolamide may be better tolerated due to its pH, and also it has a better efficacy as compared to the dorzolamide. And if we see the efficacy of the dorzolamide, it's slightly inferior to the beta blocker, that is timolol maleate, but slightly superior to the betoxolol. Topical carbonic anhydrase inhibitor usually not used as a first line or a second line drugs. They are often preferred molecules in a secondary glaucomas. For primary glaucomas, they are used either as a switch or as an add-on molecule. Can be used in a pediatric glaucoma, but in a pregnant lady, it should not be used. It should be avoided, at least in the first trimester, because of the possible teratogenicity of this. The systemic carbonic anhydrase inhibitor has lots and lots of side effects. That's why they cannot be used for a long term, like paresthesia, Mallet syndrome, anorexia, decreased libido, gastrointestinal problems, renal disorder, including the urolithiasis, aplastic anemia, and convulsion, and so on and so forth. And the side effect of the topical carbonic anhydrase inhibitors are burning and stinging sensation. It's more common with dorzolamide, complete keratitis, blurred vision, blepharitis, conjunctivitis, eye discharge, tearing, foreign body sensation. And remember that it causes the corneal edema as well, particularly those patients who has a fixed corneal dystrophy, because the same carbonic anhydrase enzyme is present in the corneal endothelial cell as well. And it causes the visual disturbances as well because of the induction of the myopia. Dr. Briganza has taught you the neuroprotection, so I will just cover the vasoprotection, or the ocular blood flow, and the carbonic anhydrase inhibitor in just 2 slides. Just now we have seen that how the carbonic anhydrase inhibitor works or acts. So see that this carbonic anhydrase inhibitors, once they do not utilize the carbon dioxide in the cell, there is an increased concentration of the carbon dioxide, and because of that, there is acidosis or acidotic conditions in the intracellular and extracellular environment. And this acidotic environment causes a vasodilatation, and this vasodilatation leads to increased blood flow. This is all theoretical, remember. Okay, there are only a few anecdotes are available, or some papers available in the literature which says that yes, it might be a vasoprotector, but remember that we do not clearly know that whether the drug reaches to the therapeutic in a therapeutic concentration to the target tissue or not. But what evidences we have is, look at this, the AVP time, that is the arteriovenous spaces time. How much time a RBC take from passing out from the arteriole to the venous. And in this study, where the dorzolamide compared with the placebo, so the AVP time, the arteriovenous spaces time, was significantly reduced in a group which was treated with dorzolamide. That means the RBCs were flowing with the accelerated pace in a patients who were treated with the dorzolamide. So this was not because of the reduction in the IOP, because when these 3 drugs were compared, the AVP was least in a group which was treated with the dorzolamide as compared to the latanoprost and the beta blocker, which are superior to dorzolamide for reduction in the IOP. So because of that, we can say that yes, they might accelerate the blood flow, but you cannot take this statement as a blanket because we do not have enough evidences in the literature. And there is a meta-analysis that which says that it's a 50-50%. So in summary, the carbonic anhydrase inhibitor is the only class of IOP lowering drug available in topical and systemic or systemic administration. The topical, though not used as a first or second line of drug of management, but often used as an add-on drug. Brinzolamide is more potent and better tolerated molecule as compared to dorzolamide. Acetazolamide often used orally to control high IOP and acute elevation of IOP. Does it have any impact on enhancing the ocular blood flow? We do not have any answer yet. So the last is the Rho kinase inhibitor. Let us see whether the ROCK inhibitor rock or not rock. So it's all new molecules. All of you might be familiar with this ROCK inhibitor. They have a novel mechanism of reducing the intraocular pressure because they are the only one which act in a most physiological way. That is how the aqueous aggression occurs in a physiological way. They accelerate that. They are highly effective both during daytime and during nighttime, and they are preferably with the additional pharmacological properties that support some other function that we might discuss in one slide each. And even if the IOP is low, the reduction in IOP is same with the ROCK inhibitor. So that is the distinct advantage, because in the normal tension glaucoma, the IOP reduction would be the same if they are reducing the intraocular pressure by around 4 to 6 millimeter. So even in NTG, they will reduce the same amount of pressure. That is not like the other drug which reduces 15, 20, 25%, 25% on the baseline. So to understand that what is the Rho kinase, the Rho associated kinase are the small GTP binding proteins. The research on the Rho kinase began way back in 1990, and the ROCK signaling pathway basically is involved in several cellular events which regulate cell shape, morphology, motility, proliferation, and smooth muscle contraction. The smooth muscle contraction, which is not regulated by calcium. And you know, this ROCK is uh, used very widely by all specialists. The neurologists, the ophthalmologists have started using from 1997. The ENT people, the cardiovascular surgeon, pulmonologists, the hepatocellular carcinoma patient, the urologist, nephrologist. So because like carbonic anhydrase enzyme, Rho kinase is also present throughout the body in almost every single tissue. So for ophthalmology, the Rho kinase are widely active in the ocular tissues, and they are implicated in the pathology of many ocular conditions, such as the corneal dysfunctions, the glaucoma, diabetic retinopathy, age-related macular degeneration. But what evidences we have so far? They are IOP lowering agents. Probably they help the corneal endothelial dysfunction, and probably they enhances the ocular blood flow as well. So the IOP lowering by ROCK inhibitor, how it acts, it increases the trabecular outflow, the relaxation of actinomycin junction in peritrabecular extracellular matrix, and alteration of the cell morphology, decreases the aqueous production through norepinephrine transporter, and decreases the episcleral venous pressure through vasodilatation. Try to learn all these mechanisms of action through this schematic diagram. This is a ciliary body. The first is that it inhibits the aqueous production through the non-epinephrine transporter, which acts like a beta blocker over here, and it reduces the aqueous humor formation. Okay. And the second and the most important, that is how the aqueous humor flow out of the trabecular meshwork and then go to the collector channel and the episcleral vein. So the most important mechanism of action is here. It is the conventional pathway of the aqueous humor drainage, and it facilitates the aqueous humor drainage through this pathway. And also, because it's a potent vasodilator, it reduces the pressure in the episcleral vein, and that's why that is a third mechanism of action. The first is here, the second is here, and the third is here. So by three mechanisms of action, it reduces the intraocular pressure. The most important, it enhances the aqueous secretion through the conventional pathway, and that is how you look at here. As I said, that it affects the cell morphology, the cell shapes. The ROCK otherwise helps in binding of these cells. So once we uses the ROCK inhibitor, the cells are separated and they provide the space to the aqueous to flow towards the canal of Schlemm, and they relaxes the trabecular meshwork as well, because they are the smooth muscle relaxant. So because of these two actions, the cell morphology is altered in uveo-scleral meshwork and in juxtacanalicular meshwork, and because of that, there is a free flow of the aqueous towards the canal of Schlemm, and that is what the physiological mechanism of the aqueous flow, and that is the mechanism of action for the ROCK inhibitor as well. So the ROCK inhibitor, they have some other mechanism of, they have some other actions as well. Number one is that the ROCK is involved in the apoptosis. What is apoptosis? Apoptosis is a genetically coded suicide program which occurs in every cell. Once the cell becomes old, automatically they commit to suicide. And this ROCK is responsible for that. And if we are using the ROCK inhibitor, then probably they should prevent or inhibit the apoptosis. And even the ganglion cells, the neuronal cell die because of the apoptosis, and that is accelerated in glaucoma. So if it is inhibited by the ROCK inhibitor, then probably it can be a neuroprotector. It is one additional mechanism. We do not have enough evidence, so don't use as a neuroprotective, but that is what is said. the increased ocular blood flow, because they are potent vasodilator, they relaxes the muscles of the blood vessel, and because of that, they dilate the blood, and that's why they again can be a vasoprotector for the eye, particularly they might be helpful in the glaucoma. And the ROCK inhibitor are supposed to reduce the scarring after the trabeculectomy. The mechanism is that why the scarring occurs? The scarring is occur because of the fibrosis. These fibroblasts, they migrate from the tenons and subtenons space towards the deeper block side, and then they convert into the myofibroblast, and they block the deeper block side. And that process is inhibited by the ROCK inhibitor. So this trans differentiation can be inhibited by the ROCK inhibitor. Similarly, as I said, that they can be a protector to the corneal endothelium, particularly in two conditions. One is the Fuchs dystrophy, and number two, if the cell gets damaged during the surgery, the fecal emulsification, then this might be helpful. As I said, that they are helpful in preventing the apoptosis, and the corneal endothelial cells also die because of the apoptosis. So if they are the apoptosis inhibitor, then probably they can enhance the survival of the corneal endothelial cells also. And number two, the corneal endothelial cells, they do not proliferate. And you must know that why they do not proliferate. It is because of the synapses. They are so jointly bind with each other that there is no space for them to proliferate. And the ROCK inhibitor, it relaxes. As I said, that they are the cell modulator. So once it relaxes, there is a space available for cells to proliferate. But again, these are all theoretical things, and we do not have enough evidences. And even there are a couple of papers available which says that the ROCK inhibitor causes the corneal edema, particularly the compact corneal edema in the epithelial cell. So which are the ROCK inhibitors are available? The first was the Riposudil, which is available in the concentration of 0.4%. Fortunately, the biosimilar molecule is available in the Indian market as well. It is available in Japanese market since 2017, and they are using it for the glaucoma, and they are also trying as a corneal protector. And there are lots of peer-reviewed publications are available. It says that at least the Riposudil is corneal protector, and it clears the cornea in aphakic bullous keratopathy and Fuchs corneal dystrophy. The other molecule is the Nitarsudil. It is available in 0.02% concentration. It's used as a once-a-day solution, and it is more potent as compared to the Riposudil. The other newer drug is the Roclatan. We have only one beta-free fixed combination, that is the combination of brinzolamide and brimonidine. The Roclatan is the second beta-free combination, not available in Indian market, but yes, it's available in the US market with the brand name of the Roclatan. It's a combination of Nitarsudil, 0.02% with the letonopras, 0.005%. And it is supposed to be the most potent anti-glaucoma drug, because both these drugs, Nitarsudil means the ROCK inhibitor, is also non-inferior to beta blocker, and letonopras also reduces the intraocular pressure by almost 35% from the baseline. So once they are combined, then there is another reduction of around 2 to 4 millimeter of mercury pressure like this. And if it is aided with some other drug separately, then yes, it has an additive effect with PG analogues, with beta blocker, and with this combo of the PG analog and the beta blocker. And it reduces the intraocular pressure in addition to the primary drug by around 1.5 millimeter to around 2 millimeter of mercury at peak and trough. So none of the anti-glaucoma drug is a side effect free. Everyone has a side effect. And the most important side effect with the ROCK inhibitor is the hyperemia. In my practice, I have seen that almost 50% of the patient, they come to you with hyperemia, and sometimes it's very irritating. And obviously the burning, irritation, corneal verticillata, like changes, subconjunctival hemorrhage are pretty common. So this is one of my patients. Probably there was a conjunctival hyperemia and lots of irritation, and because of that, the patient has rubbed his eyes. So he came to me with the subconjunctival hemorrhage, and you can see that the corneal verticillata. And once you discontinue the drug, then this verticillata disappear. You can see that the subconjunctival hemorrhage and significant hyperemia following installation of the ROCK inhibitor. So in summary, ROCK inhibitors, yes, it lowers the IOP. It might be a neuroprotective, we don't know as yet. It might increase the ocular blood flow as well. We have a very, very limited experience with ROCK inhibitor in ophthalmology. And it has the potential to reduce scarring after glaucoma surgery. It also time only will tell us. And it preserves the corneal endothelium. I have seen 2 or 3 of my patients where the corneal edema reversed, but again in pseudophakic villus keratopathy, but again they presented with corneal edema after 2-3 months. And it might be protective in diabetic retinopathy and macular edema. There is a separate mechanism. So probably, I might be running out of time. So in summary, the pilocarpine is 150-year-old drug, but it still has an important role to play in angle closure disease and occasionally used in primary open angle glaucoma as well. Hyperosmotic agents are very useful in acute elevation of IOP. Carbonic anhydrase inhibitor is only anti-glaucoma drug which can be given by topical as well as systemic route. Topical are used as a third-line drug, but maybe initial choice in some of the secondary glaucomas, particularly the uveitic glaucoma. Acetazolamide is only anti-glaucoma pills available to use. The ROCK inhibitor is an exciting molecule. Whether they will ROCK in future or not, we do not know because we have a very, very limited experience with that molecule. Thank you very much for your patience hearing.
Thank you so much, Dr. Prateep, for that wonderfully comprehensive talk on these classes of anti-glaucoma medication. I would ask Dr. Harsh to give us his thoughts at this moment. We have lots of questions to go through.
You bet. Thank you, Dr. Prateep. I think it was wonderfully done. And I'm surprised there are questions because I think he clarified everything so beautifully. So just to give some of the tips to the youngsters, he has said everything, but I'm just trying to reiterate 1 or 2 points that pilocarpine is a drug that works when nothing else works. At many a times in open angle glaucoma, angle closure glaucoma, when we have had all drugs, nothing is working, this will reduce the pressure and sometimes so much that we can't believe it. Again, the use of acetazolamide or Diamox, as it is more popularly called, you must remember that many a time people just give so many, they will give 2 tablets 5 times a day, whatever they want. But please be careful, the maximum dose is 1 gram. So 1 tablet given 4 times a day is the maximum that will work. More than that does not work. There's another concept of using a low dose Diamox now as an additional to the maximum medical therapy if the patient can tolerate it, especially for his gut. And you have to keep repeating the liver function test, kidney function test, and the electrolytes regularly to see that it is not creating a problem. Because anybody whom you put on Diamox, you have to be very, very careful because many times what happens is these are old patients. They'll go into electrolyte imbalance before anybody realizes they are admitted. And many times the doctors and the relatives cannot correlate that it occurred because of the use of acetazolamide. And the same may happen with glycerol. Again, whenever you are giving mannitol, you have to be very careful, check that there is no heart failure over there, because we have seen patients in front of our eyes go into left ventricular failure. So be very careful about that. And CAI inhibitors, Dr. Prateep already told everything. Just one point that he has already told, but you be careful that if the cornea is decompensated, you have to not use it. And in any of these, any sulfa allergy, you have to be very, very careful. And that's about it. Please go ahead, Vanita.
Yeah, I just wanted to make a point about CAIs and pilocarpine as well. Yeah, that they should not really be used. CAIs, carbonic anhydrase inhibitors, should not be used in eyes which have received a corneal graft, because they can cause failure, decompensation, and ultimate failure. So we should be trying other classes of drugs there. Prostaglandin analog can also be tried, provided there is no inflammation, of course. And where pilocarpine is concerned, once a patient is on pilocarpine and has been known to be an angle closure, or you don't know what the angle status is, pilocarpine generally tends to open up the angle. So you cannot say whether the patient is actually angle closure or open angle. But one of the questions is that what is the mechanism of paradoxical angle closure in pilocarpine?
You want me to reply?
Yes, please.
Go ahead.
Okay. Okay. So it is very important. There are two mechanisms which works. Number one is called as the inverse pupillary block, and number two, it pushes forward the iris lens diaphragm. So the anterior chamber volume reduces with the usage of the pilocarpine. So there is crowding of the iris over the angle because of that. So we have to be very, very careful about these two conditions. And inverse pupillary block can be avoided comfortably by doing the peripheral iridotomy first. So the inverse pupillary block condition you will not face. But the iris lens diaphragm will move forward and may cause crowding if the entry chamber is very, very shallow.
Right. And there was a point that you made that you can give pilocarpine in clear lens. Obviously, you avoid in cataracts because they tend to get much worse vision, and so they are intolerant to it. But does pilocarpine also not induce cataracts?
So yes, there are some point which needs to be remembered, which I did not tell you, and probably it was missed out. Number one is the pilocarpine is most notorious for tachyphylaxis, which I missed out. And number two, yes, the cataractogenesis can occur not only with the pilocarpine, but even the prostaglandin analog as well. So obviously, pilocarpine you don't use as a first-line drug except in the angle closure disease. But as Dr. Harsh said, that when nothing works, then the pilocarpine comes to your rescue and initiate the pilocarpine. And once you have reached to a point where you have to start the pilocarpine, that means that the time has come where you should think of taking the patient for surgery.
So just wanted, I don't know whether we missed it out or I missed out listening to that. But just another point, Prateep, do you think we should give a drug holiday? Because classically, sometimes after every 2 weeks of use of, if there is a long-term pilocarpine use, then we can call the patient one day and dilate in front of us just to make sure that the pupil is mobile. So do you think it's worth it?
Yeah, I think, both the things work very well, because your glaucoma patient comes to you regularly. And it is always a nice thing to do that you dilate the pupil with phenylephrine and tropicamide, and with that, the pupil will dilate enough, and you make sure that the pupil is still dilating and the sphincters are not overacting. So that is one thing. And for tachyphylaxis, yes, once you feel that the pilocarpine is no more working, then give a holiday like we used to give for the beta blocker in our initial days. So the same way you can do with the pilocarpine. So giving a holiday will work in a both way. The pupil will become immobile, not remain immobile. It will become mobile, and the tachyphylaxis also will be taken care of. And one point, Harsh, you have made, again, which I missed out. always remember that for PG student, I'm telling it, you must give the potassium. I always give a potassium supplement whenever I give a systemic carbonic anhydrase inhibitor. You brought out that point. Thank you very much, because I missed out. I would have mentioned during my talk.
A point related to hyperosmotics that has been raised is, should electrolytes be tested routinely before giving it?
Yes, Harsh already has made it very clear that for all hyperosmotic and when you are giving a systemic carbonic anhydrase inhibitor, it is better to test the electrolyte because only hyperosmotic condition is that when you have to give for a long term. You want to give glycerol for a long term, then electrolyte has to be tested. But if you have to give in emergency, then you can't wait for that. If the patient condition is okay, if the patient, a young patient, 40, 50 years old with no systemic history, comes to you with an acute angle closure, then obviously you will not wait for the electrolyte and you have to give the IV mannitol immediately. So I would not recommend. And if you have to give during surgery, then you cannot test the electrolytes.
Basically, what we are trying to say is that hyperosmotics should not be given for a long time or prolonged period. And if they are, then we should be careful about the electrolytes. There are a lot of questions related to switching in between intra-class. So let's start with the prostaglandin analogues, although I know you have not covered it, but they have this query. Do you need to go through every drug within that class to actually say, fine, prostaglandin analog, you're a non-responder?
That's a very good question.
So when the prostaglandin lecture was going on, Manita has pointed out that prostaglandin can be rotated, and yes, I do agree that from latanoprost you can switch to travoprost, and from travoprost you can switch to bemetoprost, and it works. But all these drugs which act through the autonomous nervous system, they are a different class of drug, and these drugs you cannot compare with the prostaglandin analogues. So even I will put the carbonic anhydrase inhibitor also into that class. So which you cannot rotate, because once the receptors are saturated, then they will not work. So for the prostaglandin analog, somehow it does work.
Okay. Then that is clear that CAI need not be switched intra-class. If Dorzox is not working, then dorzolamide is not working, then likely brinzolamide will not work. But can you give oral and topical CAI together?
Yes. What
I have been asked this question hundreds of times.
Yeah. But I will tell you what the publication says, that yes, if the patient has an acute elevation of IOP, which cannot be controlled by the topical drugs, then you give the systemic carbonic anhydrase inhibitor, and then subsequently the role of systemic carbonic anhydrase inhibitor can be taken over by the topical drugs. That is either by brinzolamide or dorzolamide. There is not a matching reduction in the IOP. There will be slightly less reduction in the IOP, but they take over the function of systemic carbonic anhydrase inhibitor to some extent.
Right. I will tell you that I have tried to find the answer for this question. I've tried very hard. I have found a few publications which have said that actually the isoenzymes of carbonic anhydrase, there are 12 types. And how the topical works and which isoenzyme it works on is different from the isoenzyme that is targeted in oral. And so, one approach is definitely try and reduce. If there is acute rise, try and reduce with oral, and then subsequently switch over to topical, or you can start with both and stop the oral and continue with the topical.
So that's a very complicated issue, like rock as A, B, C, and in each category there are many isoenzymes.
Yes, yes.
Similarly, the CAI has 1 to 12, and there are so many isoenzymes along with that. So we are more interested in carbonic anhydrase inhibitor 2, carbonic anhydrase 2, and then it has several. So which drug act where you don't know. And the ROC and CAI present throughout the body, and where all they will have their effect, really we do not know. So it's all very, very difficult things to answer.
Another question about switching intra-class is about alpha agonists. We don't have very many alpha agonists available in our country. So I don't know why this question has been put through.
Yeah, even the
we do have different concentrations, but generally speaking, you want to go with the lowest concentration, which is 0.1 brimonidine. Okay, can ROC inhibitors cause corneal verticillata? And if so, which drug can it be substituted with?
Which drug can it be?
Substituted with.
See, if you have a corneal verticillata, patient is complaining of blurred vision, then obviously you have to discontinue the ROC inhibitor and you have to switch on some other drug, any drug, because anyway the ROC inhibitor are not the first or the second line of treatment. They comes as a third or fourth. So there are many drugs available. You have a carbonic anhydrase inhibitor, you have alpha-2 agonist, you have a beta blocker. So any drug can take over the function of the ROC inhibitor. And ROC inhibitor said to be non-inferior to beta blocker, but at least the biosimilar I did not find in my practice. I found that they are either equivalent or they are slightly inferior to the beta blocker. So yes, you can substitute with any of these.
Right. This question has surfaced once again. What is the safest anti-glaucoma medication in pregnancy and lactation?
So, there is no drug which is the safest in pregnancy and lactation. But alpha-2 agonist is considered to be the safest amongst all. It falls into category 2. So that is the one. So if I have to select, if my SLT is not working and if the hemodilution has not reduced the intraocular pressure significantly, and if I have to give any one drug, then probably I would prefer alpha-2 agonist over any other drug, particularly in first and second trimester.
So definitely avoid carbonic anhydrase inhibitor in the first trimester and avoid alpha agonist in lactation.
Okay.
Yeah. That's, as
Even
long as you remember what to avoid. And relative contraindication of prostaglandin analog in the third trimester, because there might be concerns about premature labor. I'm not sure that actually happens with topical minor doses, but anyway, that is a theoretical consideration. And I think we will close with one last question today. Do we routinely follow monocular trial of anti-glaucoma medication?
This question I asked to Dr. Braganza as well. I used to do, but I have stopped using for several reasons. Number one, it is labor intensive. The patient has to come to you again and again. And most of the drugs, they have a contralateral effect. So for a couple of these reasons, I have stopped doing the monocular. I don't know whether any one of you are doing.
No, I don't think
I have never done.
So just one last point I want to make for that lactation and this thing period is that once the pregnancy is over and the lactation is on, both of you, do you think that we should be a little careful about the beta blockers because they can cross over and kids can sometimes get asthma and all that, which people
respiratory, reduced heart rate also.
So would you think that in those situations, CAIs and PG analogues would be preferred?
Yeah.
Absolutely.
Can we tell them that?
Yes.
Absolutely.
Yes.
I think we'll tell them to avoid beta blockers to begin with, right?
Yeah.
Beta blocker, alpha-2 agonist, and even the pilocarpine.
Alpha-2 we have already
told. All drug acting through the autonomous nervous systems are otherwise notorious.
Thank you very much, Prateep and Vanita, for conducting.
I just want to share, maybe there's another question.
If it is relevant.
Yeah, ROC inhibitors causing vasodilation is it the drug or is it the preservative which is causing the vasodilatation?
I don't know. It's a drug.
Oh my God.
It acts over the smooth muscles, which are, the calcium independent action. So it is mediated with the ROCK inhibitors, and it relaxes the smooth muscle around the blood vessels, and this is why the blood vessels are dilate, and that is the mechanism of action.
Right. So I just want to share one case of Ripacidil that at a time when we didn't have much experience and did not know much about its effects on the cornea, I gave this gentleman, I just share my screen. My screen is stuck. Sorry, never mind. So anyway, I did see not just corneal verticillata, which is talked about not on the epithelium, but he developed epithelial stain.
I think Vanita is stuck like Prateep sometimes. Then you transferred that to her. So I think
contagious.
So I think can we close?
Yeah, I think.
Thank you very much, Prateep. It was such a wonderful lecture.
Thank you. Thank you for opportunity, Harsh.
We'll see next time.
Thank you. I learned from you. Thank you.
Thank you, sir.
Thank you, Christy, and Rolika is not here today. Thank you, Vanita, if you are listening. We can't hear you, but you might be listening to us. Thank you, Harsh. Thank you, Santosh. Thank you, Christy. Thank you, Rolika. Bye.
Bye,
Thank you,
sir.
sir.
Good night.